Assalamu alaikum wa rahmatullahi wa barakatuh. Today, I will speak about antifungal treatment. Regarding the objectives, at the end of this lecture, you should be able to list the potential drug targets in fungal infections. You should be able to name useful agents in the treatment of systemic and superficial fungal infection. You should know the mechanism of action, pharmacokinetics, and the major adverse effects of each of these drugs. Fungal organisms are classified into yeast, which is unicellular, round in shape, like Candida, Cryptococcus, and Pneumocystis. The other group is molds, which is a multicellular filamentous organism, like dermatophytes, aspergillus, and mucormycosis. The third type is dimorphic fungi. This dimorphic fungi is usually present in the form of molds in suitable environmental conditions, but in high temperature or unsuitable environmental condition, it takes the form of yeast. It includes blastomyces, histoplasma, coccidiosis, and sporothrics. Fungi different from bacterial infection in the following items. Fungi has a rigid cell wall, which is formed from chitin glucans, not peptidoglycan like bacteria. Also, its cell membrane is formed mainly from ergosterol, not cholesterol as bacteria and mammalian cell. And fungi also can resist antibiotics. Antibiotics can kill bacteria, but can't affect or kill fungal infection. Fungal infection is known as mycosis. It may be superficial infection or systemic infection. Superficial mycosis is very common, while systemic mycosis is less common. Superficial mycosis can affect the skin, mucous membrane, and subcutaneous tissue, inducing cutaneous or mucocutaneous or subcutaneous fungal infection or mycosis. Cutaneous infection can be caused by dermatophytes, inducing tinea. Mucocutaneous mycosis can be induced by candidiasis. Subcutaneous mycosis can be induced by sporotrichosis. On the other hand, systemic mycosis can induce fungemia, which means the presence of fungi in the blood, pneumonia, which means inflammation of the lung, meningitis, which means inflammation of meningeal sheath or meningeal membranes around the brain. It may be primary systemic infection or opportunistic systemic infection. In primary systemic infection, it can affect normal person with normal immunity. So it needs large dose of fungal infection to can induce mycosis. While in opportunistic infection or opportunistic systemic infection, it can be induced in immunodeficient patient, especially AIDS and organ transplantation. In this condition, the immunity of the person is very low, so any dose or any volume of fungi can induce systemic infection. Primary systemic infection can be induced by blastomycosis, histoplasmosis, and coccidiomycosis, while opportunistic infection can be induced by candidiasis, cryptococcosis, pneumocystis, and aspergillosis. Regarding the mechanism of action of antifungal drugs, Antifungal drugs can kill the fungi through many mechanisms. The first mechanism is distortion of hyphae and the stoppage of fungal growth, like tolnaftate. It can induce inhibition of cell wall synthesis through inhibition of beta-D-glucan, like caspofungin. It can induce disruption of cell membrane function by binding to ergosterol and the formation of cell membrane pores. These pores allow to essential electrolytes and the nutrient to escape from the fungi, especially potassium, leading to death of the fungi, like amphotericin B and nystatin. Antifungal drugs also can inhibit cell membrane synthesis through inhibition of one or more of ergosterol synthesis, like azoles, terbinafine, and amorolfine. Antifungal drugs also can inhibit fungal protein synthesis, like tavaborol. They also can inhibit fungal mitosis or division, like graziofulvine. They also can inhibit fungal nucleic acid synthesis, like 5-fluocytosine. This diagram summarizing the mechanism of action of antifungal drugs. The first drug can stop growth and distort hyphae synthesis, like tolnaftate. They can also inhibit cell wall synthesis through inhibition of beta-D-glucan, like caspofungin. They can disturb cell membrane function through binding to ergosterol formation of pores, leading to escape of essential electrolytes and metabolites and entrance of water by osmotic drawing of water into the fungi, leading to rupture of the fungi. The drugs which can act by this mechanism are amphotericin B and nystatin. They also can inhibit cell membrane synthesis through inhibition of ergosterol synthesis in endoplasmic reticulum, like terbinafine, which inhibits squalene epoxidase enzyme, leading to inhibition of ergosterol synthesis. Azoles, which inhibits lanosterol demethylase enzyme, leading to inhibition of ergosterol synthesis also, or amorolfine, which inhibit reductase and isomerase enzyme, leading to inhibition of synthesis of ergosterol. Antifungal drugs also can inhibit protein synthesis through inhibition of transfer RNA synthetase, like tavaborol. They can also inhibit mitosis through binding to microtubules and disruption of mitotic spindles, like graziofulvine. The last mechanism is inhibition of nucleic acid synthesis by 5-fluocytosine. Fluocytosine converted by fungal cytosine deaminase to 5-fluorouracil, which inhibits thymidine synthesis and inhibition of DNA synthesis. Now we will discuss the pharmacology of each antifungal drugs. We will start by amphotericin B. Amphotericin B is a water-insoluble drug. So if it is taken by oral administration, it will not be absorbed. So it is taken by a slow intravenous infusion. There are two forms of amphotericin B. The conventional form which is binding of amphotericin B to sodium deoxycholate to enhance its pharmacokinetics. The other form is known as artificial lipids or liposomes. This liposomes is formed of two layers from phospholipid, which are more similar to cell membrane of human cell. And inside these liposomes, amphotericin B drug is present. Okay. At the surface of these liposomes, there is antibody against ergosterol of the fungi. So liposomes are targeted ergosterol in the fungi and they bind only to ergosterol in the fungi and they can't reach mammalian cell. So liposomes have very low affinity to mammalian cell, okay, because at the surface of liposomes there are antibodies against ergosterol. So ergosterol bind to liposomes, allowing it to enter the fungi only, can't enter mammalian cell. So liposomes have better tolerability and less toxicity because they are targeting the fungal cell only. But unfortunately, liposomes are very expensive. Amphotericin B has high affinity to plasma protein binding and also have very long duration. Its T half extended to 15 days. Inflammation increase amphotericin B penetration into various body fluids, but it has limited passage to CSF, vitreous humor in the eye, synovial fluid in the joint, and peritoneal fluid. So if there is any fungal infection in these sites, amphotericin B should be locally injected to these fluids. Amphotericin B is excreted mainly in urine, okay, and has nephrotoxicity. Regarding mechanism of action of amphotericin B, as we said before, it can disrupt cell membrane function through binding to ergosterol and formation of pores, allowing electrolytes, especially potassium, and small molecules to leak from the fungi and the entrance of water into the fungi, leading to its bursting. Regarding the spectrum and the uses of amphotericin B, amphotericin B can be used for treatment of severe systemic infection, especially meningitis, by injection into the CSF. It can be combined with flucytosine as induction therapy for treatment of cryptococcosis and invasive candidiasis, followed by maintenance therapy with fluconazole. Why we bind flucytosine with amphotericin B? Because amphotericin B induces pores in the cell membrane, and these pores allow entrance of flucytosine, which inhibit DNA synthesis inside the fungi. Amphotericin B can be used also for treatment of leishmaniasis, which is a protozoa. It is used mainly for mucocutaneous leishmaniasis and visceral leishmaniasis. If the fungi decrease its content from ergosterol, it can lead to resistance to amphotericin B. Regarding side effects of amphotericin B, amphotericin B has a narrow therapeutic window, so it is unsafe drug. Can induce fever and chills, usually subsided with the second injection, and can be prevented by pre-administration of corticosteroids or non-steroidal anti-inflammatory drugs. It can also induce nephrotoxicity, which is very serious side effect with amphotericin B. Nephrotoxicity usually occurred with conventional type or conventional form of amphotericin B. It may be reversible after stopping the drug. Its severity can be decreased by adequate intravenous fluid administration and hydration. It's very important to prevent other nephrotoxic drugs with treatment of amphotericin B, like aminoglycoside. So, co-administration of amphotericin B with other nephrotoxic drug can induce renal failure. So, it is contraindicated to give any other nephrotoxic drug with amphotericin B. Amphotericin B can induce also hypotension, hypokalemia, anemia, and thrombophlebitis after intravenous injection. And this thrombophlebitis can be prevented by co-administration of heparin with amphotericin B. Regarding nystatin or nystatin, nystatin has similar structure and the mechanism of action to amphotericin B. Nystatin only used for topical administration because it is negligibly absorbed from gastrointestinal tract, not absorbed from gastrointestinal tract. And if administered orally, it will not be absorbed and act locally in the gastrointestinal tract. If it is used by intravenous injection, it can induce systemic toxicity, mainly nephrotoxicity. So parenteral nystatin administration is contraindicated. So its usage is limited to topical administration, mainly for treatment of mucocutaneous candidiasis in different body parts. Can be applied for cutaneous candidiasis in the form of cream, and can be taken orally in the form of syrup or suspension for treatment of gastrointestinal candidiasis. It is not absorbed from gastrointestinal tract, so it acts locally in the gastrointestinal tract for treatment of gastrointestinal candidiasis. It can be also given intravaginally in the form of cream or vaginal suppository for treatment of vulvovaginal candidiasis. Regarding its adverse effects, it can induce local irritation when it is applied topically or locally. Oral form of nystatin, in the form of syrup or suspension, can induce nausea and vomiting. And as we said before, it acts locally in the gastrointestinal tract and do not absorb it to the systemic circulation. Now we will discuss azoles. Azoles are a group of drugs. These drugs are metabolized by cytochrome B enzyme 450, except busaconazole. And all azole drugs, even busaconazole, can inhibit cytochrome B3A4. So all azoles drugs can inhibit cytochrome B3A4. And all azole drugs metabolized by cytochrome B450 except busaconazole. So busaconazole not metabolized by cytochrome B but can inhibit cytochrome B3A4. These groups or these drugs are contraindicated in pregnancy except if their benefit outweigh the risk. They are classified as a class C for pregnancy. We have two groups of azoles. The first group is imidazoles. The second group is triazoles. Imidazoles are ketoconazole, miconazole, and clotrimazole. Their absorption is very limited from gastrointestinal tract. However, ketoconazole can be absorbed. Okay, has better absorption than miconazole and clotrimazole. Their spectrum is very narrow. They affect only dermatophytes and candidiasis. And usually dermatophytes and candidiasis induce mucocutaneous infection. So imidazoles are usually used for local infection by topical administration. The second group is triazole. Triazoles includes fluconazole, itraconazole, and voriconazole. They are used for local and systemic infection because their pharmacokinetics is better than imidazole group. Although these drugs have similar mechanisms and spectrum, but their pharmacokinetics and therapeutic uses vary significantly. Regarding the mechanism of action of azoles, they inhibit C14 alpha demethylase enzyme. This enzyme is one type of cytochrome B450. So most of these drugs can inhibit, or all of these drugs can inhibit cytochrome B3A4 in the liver because they can inhibit cytochrome B450 in the fungi through inhibition of alpha demethylase enzyme. Inhibition of alpha demethylase enzyme leading to inhibition of demethylation of lanosterol to ergosterol, leading to inhibition of ergosterol synthesis and disruption of membrane function in the fungi. The fungi can resist azoles through mutation in alpha demethylase enzyme and also through efflux pumps that pump azoles out of the fungi. Regarding ketoconazole, which is one member of imidazole group, it can be administered topically or orally, and oral absorption is enhanced by food and HCl. It has high binding to plasma protein, but its passage to blood-brain barrier or to the brain is very limited. It is metabolized in the liver by cytochrome B450, leading to interaction. So drugs which enhance cytochrome B will destruct ketoconazole, and drugs which inhibit cytochrome B will inhibit ketoconazole metabolism. Ketoconazole can inhibit cytochrome B3A4, also leading to drug interaction. Metabolites of ketoconazole are excreted in bile. Ketoconazole has narrow therapeutic window, affects mainly dermatophytes and candidiasis, but its side effects are dangerous side effects. So it is unsafe drug and has narrow therapeutic window. It can inhibit adrenal function, has anti-androgenic effect and anti-glucocorticoid effect because it inhibits steroid synthesis in the suprarenal gland. Ketoconazole also has severe liver toxicity, and its topical administration can induce dermatitis, irritation, and even edema. Other members of imidazole group are miconazole and clotrimazole. Both drugs have limited gastrointestinal tract absorption. Clotrimazole is available as lozenge, while miconazole is available as buccal tablet for treatment of oral moniliasis or oral candidiasis, also known as oral thrush. Regarding their side effects, like topical application of ketoconazole, they also can induce dermatitis, valvular irritation, and edema. The fourth azoles drug is fluconazole. It is the fourth azoles drugs and the first triazole drug. This table showing the difference between ketoconazole and fluconazole. Regarding the routes, ketoconazole is usually taken or administered by oral administration and topical administration, while fluconazole is usually taken by oral administration and intravenous administration. Absorption of ketoconazole is enhanced by food and HCl, while absorption of fluconazole not enhanced by food. Ketoconazole has low blood-brain barrier passage and penetration, while fluconazole has high CNS penetration, so it is usually used for treatment of meningitis. Regarding the plasma protein binding and hepatic metabolism, ketoconazole has high plasma protein binding and excessive hepatic metabolism, while fluconazole has minimal plasma protein binding and hepatic metabolism. Regarding drug interactions, ketoconazole has more drug interactions than fluconazole. Ketoconazole is excreted in bile, while fluconazole is excreted in urine, so it needs dose adjustment in renal impairment. Ketoconazole can induce anti-androgen effect and anti-glucocorticoid effect, while fluconazole don't has any endocrine effect. Ketoconazole is unsafe drug, so its therapeutic window is very narrow, while fluconazole is a safe drug and its therapeutic window is wide. Regarding adverse effects, ketoconazole has more and severe side effects, while fluconazole has less and mild side effects in the form of gastrointestinal tract upset and allergy. Regarding the spectrum and uses, fluconazole is the first triazole, but it has the less activity and has very narrow spectrum. Its spectrum limited to yeasts and some dimorphic fungi. It is usually used for treatment of candida, coccidioidomycosis, and it is the first drug of therapy for treatment of cryptococcosis after induction of amphotericin B and flucytosine. So we will start by amphotericin B and flucytosine. After that, we give maintenance therapy of fluconazole for treatment of cryptococcosis. Fluconazole can be used for prophylaxis in immune-compromised patients, especially HIV-infected patients, and bone marrow transplantation due to immune deficiency in these patients. So fluconazole can prevent or protect these groups of patients from fungal infection. The fifth azole drug and the second triazole drug is itraconazole. Itraconazole is similar to fluconazole but has a broader spectrum and extensively metabolized by the liver with more interactions like ketoconazole. This is present in capsule or tablet form, and the capsule and the tablet form, their absorption are increased by food and acidic beverage and HCl. While the solution form has better absorption in empty stomach. So capsule and the tablet usually administered with food to enhance their absorption. While solution is usually taken or administered on empty stomach because solution absorption is enhanced by empty stomach. Itraconazole has a better distribution, but unfortunately can't reach CNS. So itraconazole is not suitable for treatment of fungal meningitis. Itraconazole can be excreted in both bile and urine. Bile like ketoconazole and urine like fluconazole. Regarding the uses of itraconazole, it is the first line of therapy for dermatophytes. It can also use for treatment of dimorphic fungi like blastomycosis, histoplasmosis, sporotrichosis, coccidiomycosis. Because itraconazole is a very potent drug and has a wide spectrum, so it can treat most of fungi, can treat all dimorphic fungi, and it is considered the first line of therapy for dimorphic fungi, and also can treat dermatophytes, which is a mold. Itraconazole also is very effective against Candida and Aspergillus, but usually not used for treatment of this fungal infection due to availability of more effective drugs with less side effects. Because itraconazole can induce severe side effects in the form of liver toxicity, cardiotoxicity, as it is considered a negative inotropic drug, decreases contractility of the heart, can also induce edema, hypokalemia, and hypertension. Regarding voriconazole, it is similar to fluconazole, but it has broader spectrum and excessive metabolism in the liver, so it can induce more drug-drug interactions. Voriconazole is usually used as a first-line drug for treatment of aspergillosis. It replaces amphotericin B. It is also effective in treatment of invasive candidiasis and dermatophytosis. It can induce visual side effects and auditory hallucination and hepatotoxicity, plus side effects of fluconazole, which are gastrointestinal tract upset and allergy. The last azole drug is busaconazole. Its structure is similar to itraconazole. It has broad spectrum activity against fungi. It is not metabolized by cytochrome B450, but eliminated by conjugation with glucuronic acid. It has potent inhibitor effect on cytochrome B3A4, so it is liable for multiple drug-drug interaction. Busaconazole is available as oral suspension, oral tablet, and intravenous formula. Its oral bioavailability is very low, and its absorption is enhanced by food or HCl, like acidic beverage. It has a long T-half, usually used for treatment and prophylaxis of invasive Candida and Aspergillus. Regarding its side effects, it can induce headache and gastrointestinal tract upset. The next group is echinocandins. Echinocandins can inhibit synthesis of fungal cell wall through inhibition of beta-D-glucan synthesis. Echinocandin is very effective against Candida and Aspergillus. The first member of echinocandins is caspofungin. Caspofungin is used only by intravenous infusion, very slow infusion, because rapid injection can induce histamine-like reaction in the form of hypotension, bronchospasm, and itching. It's metabolized by cytochrome B450. So inducers to this enzyme can lead to marked destruction of caspofungin, and its dose should be increased, while inhibitors of this enzyme can induce toxicity from caspofungin, and its dose should be reduced. Caspofungin requires dose adjustment in liver insufficiency. It is contraindicated to give cyclosporin, which is an immunosuppressive drug, with caspofungin, because co-administration of both drugs can induce marked or severe increase in liver enzymes. Regarding the uses of caspofungin, it can be used as a first line for therapy of invasive candidiasis and candidemia. It is considered the second line of therapy for invasive aspergillosis. Regarding its side effects, it can induce nausea and vomiting, fever, flushing, and thrombophlebitis during intravenous administration. And also it needs heparin injection. The second and the third member of echinocandins are micafungin and anidulafungin. They are similar to caspofungin, but they are not metabolized by cytochrome B450, so there is no drug-drug interaction. They don't need dose adjustment in renal impairment or moderate hepatic dysfunction. Regarding graziofulvin inhibit mitotic spindle, leading to inhibition of fungal mitosis. So it inhibits division of the fungi. It is taken by topical or oral administration, and its oral administration or oral absorption is enhanced by high fatty meals. Graziofulvin has a high affinity to keratin, so it is accumulated in skin, hair, and nails because it tightly binds to keratin, especially keratin in the precursor cells, leading to prevention of fungal infection to the precursor or the newly formed cells. Graziofulvin can treat fungal infection in old cell or already infected cell, but can protect the newly formed cell from fungal infection. So, treatment with graziofulvin needs long time. It can reach to 1 year because its treatment depends on the replacement of old infected cell by new normal cell. Graziofulvin can induce cytochrome B450 enzyme. So its induction to this enzyme can lead to metabolism or destruction of other drugs like anticoagulant drugs. So if you give graziofulvin with anticoagulant drugs, you should increase the dose of anticoagulant drug, because graziofulvin enhance metabolism of anticoagulant drugs. Regarding the uses of graziofulvin, it can be used for treatment of cutaneous dermatophytosis. It can also be used for treatment of onychomycosis, which means fungal infection of the nail, but terbinafine is used nowadays for treatment of onychomycosis instead of graziofulvin. So terbinafine considered a first choice for treatment of onychomycosis instead of graziofulvin. Regarding side effects of graziofulvin, it can induce photosensitivity, hepatotoxicity, and teratogenicity. So it is contraindicated in pregnancy. Now we will discuss a new group of antifungal drugs. which is known as squalene epoxidase inhibitors. This group of drugs can inhibit squalene epoxidase enzyme. Inhibition of this enzyme leading to prevention of transformation of squalene into ergosterol. And formation of ergosterol leading to defect in cell membrane of the fungus. And also accumulation of squalene is very toxic to the fungus, leading to formation of membrane pores and permeability increased and death of the fungi. The first member of squalene epoxidase inhibitor is terbinafine. Terbinafine can be used by topical administration and oral administration. Its oral absorption is very good, but it undergoes first pass metabolism in the liver, so it has very low bioavailability, 40%. Why? Because it is extensively metabolized by first pass metabolism in the liver. It has high plasma protein binding, accumulate in skin and nail and fat. It can pass to the placenta and milk. It has very long T-half. It can reach about 400 hours. It is metabolized by cytochrome B450 and also can inhibit cytochrome B subtype 2D6. Is excreted in urine. Compared to grazofulvin and itraconazole in treatment of dermatophytosis, terbinafine is most effective, better tolerated with short duration of therapy up to 3 months. So terbinafine considers the first line of drug therapy of onychomycosis and cutaneous dermatophytosis. Regarding the adverse effects of terbinafine, it can induce gastrointestinal tract upset, taste disturbance, visual disturbance, and liver dysfunction. In renal and hepatic impairment, terbinafine therapy is contraindicated. The second and third member of squalene epoxidase enzyme inhibitors are naphthalene and butenafine. Naphthalene and butenafine are used for topical treatment of dermatophytosis. They are used for 2 weeks therapy. Now we will discuss 5-flucytosine antifungal drug. 5-flucytosine enters the fungal cell by cytosine-specific permease enzyme. This permease enzyme is not found in mammalian cell, so 5-flucytosine usually can't enter the normal mammalian or human cell. This subsequently converted to 5-fluorouracil and 5-fluorodeoxyuridine 5-monophosphate, which disrupt nucleic acid and protein synthesis. Co-administration of amphotericin B with flucytosine, leading to increasing of permeability to flucytosine, allowing more flucytosine to penetrate the cell and leading to synergistic effect. 5-flucytosine is good orally absorbed, can pass blood-brain barrier, excreted in urine, and its dose should be adjusted in renal impairment. It is contraindicated in pregnancy. This diagram showing the mechanism of action of flucytosine, which enter into the fungal cell by the effect of permease enzyme. After its entrance to the fungal cell, it is transformed by cytosine deaminase enzyme into 5-fluorouracil, then transformed into 5-fluorodeoxyuridine monophosphate. 5-fluorodeoxyuridine monophosphate inhibit the thymidylate synthase enzyme. This inhibition of thymidylate synthase enzyme leading to prevention of transformation of the deoxyuridine monophosphate into deoxythymidine monophosphate and inhibition of DNA synthesis inside the fungi. Resistance of permease enzyme and the resistance to deaminase enzyme can lead to flow cytosine resistance. So mutation or resistance or a change of the permease and the deaminase enzyme leads to ineffectiveness of flow cytosine treatment and the resistance to flow cytosine treatment. And this resistance is very common to flow cytosine. So usually flow cytosine not used as a monotherapy and should be combined with other drugs. Why? Because resistance to flow cytosine is very high through mutation in deaminase enzyme or permease enzyme. It can be used for treatment of systemic fungal infection with itraconazole for treatment of blastomycosis and with amphotericin B as induction therapy for treatment of cryptococcosis and invasive candidiasis. And after that, we can give fluconazole as a maintenance therapy. Flucytosine is unsafe drug. It has very narrow therapeutic window. It can induce bone marrow suppression, but it is reversible, and severe hepatotoxicity, and also it is reversible. It can also induce inflammation of the intestinal tract, especially small intestine and colon, and can induce nausea, vomiting, and anorexia. Regarding amorolfine, amorolfine inhibits ergosterol synthesis through inhibition of reductase and isomerase enzyme. Is used topically for treatment of onychomycosis. Regarding tavaborole, tavaborole inhibits protein synthesis through inhibition of transfer RNA synthetase enzyme. Tavaborole is active against the Candida albicans and approved for treatment of onychomycosis. Duration of therapy lasts for about 1 year. Regarding cyclopyrox, it inhibits transport of essential elements in fungal cell, disrupting the synthesis of DNA and RNA plus proteins. Cyclopyrox is used for treatment of seborrheic dermatitis and dermatophytosis or tinea. Regarding tolnaftate, tolnaftate distorts the hyphae and stunts fungal growth. It is applied as a topical cream, gel, powder, aerosol, or solution. It is used for treatment of cutaneous dermatophytosis, which is known as tinea. It is not effective against the Candida. Why? Because tolnaftate inhibits hyphae, which is present in molds, while Candida is a yeast and do not contains hyphae. Finally, we can treat superficial fungal infection by oral nystatin, terbinafine, graziofulvin, or topical also nystatin, terbinafine, graziofulvin, plus imidazoles like ketoconazole, clotrimazole, amorolfine, tolnaftate, and tavoborole. Systemic fungal infection can be treated by amphotericin B, triazoles like fluconazole, itraconazole, voriconazole, usaconazole, casbufangin, and also flucytosine, which is usually combined with amphotericin B to induce synergistic effect. Thank you very much.